बिट्टू रोटी दे खाना बघ मिरची आणलो खाना.
तिला 7 पूर्ण व्हायचेच होते. डिलिव्हरी झाल्यानंतर म्हणजे डिलिव्हरी कठीणाचीच झाली थोडी. मग पुन्हा तो बाळ जन्माला आला तर तो रडतही नव्हता. तर म्हणजे त्याच्यामध्ये काहीच होत नव्हता. याला कुठं न्यायचा, हा नेण्यालाही गई नाही आहे ना. आपण तर गरीब माणूस, पैसा नाही दवाखान्यात नेतो मनासाठी. तर या अंजलाबाईकडे न्या, तुम्ही या बाईची मदत घ्या.
मग तो बाळ एकदम सिरियसली होता. ते घरचे लोक तर घाबरलेच, हा जगत नाही म्हणून. पण आजूबाजूचे सगळे लोक त्यांना सांगत होते, मला माहीत नाही पण त्यांना म्हणत होते की हा बाळ जगत नाही.
पण या बाईनं म्हटले का लोकांकडे लक्ष नको द्या, तुम्ही त्याची मी सांगतो त्याप्रमाणे तुम्ही त्याची काळजी घ्या. आता इतका म्हणजे 3रा महिना निघून 4था लागला तर कोणी त्याला ओळखत नव्हते का हा कुपोषित बाळ आहे.
बाई गेली पाण्यात तुम्ही शेलून पालवा. बाई गेली पाण्यात तुम्ही शेलून पालवा. पाळण्याचा दोर तुम्ही हलक्यानी हलवा. पाळण्याचा दोर तुम्ही हलक्यानी हलवा.
Gadchiroli is a remote, primarily rural, heavily forested district in eastern Maharashtra, India. A relatively poor district with a large tribal population and limited access to education and healthcare, it is the location of a remarkable initiative that has saved the lives of many infants and their mothers over the past 3 decades.
Exactly 30 years ago, when we came to Gadchiroli, in one of the initial interactions with the people, what were their main health needs, we asked them. And one of the health needs they mentioned was, our children die. Can you do something for it? So we established a measurement system in nearly 100 villages. In 1988, when we first measured it, we found that the infant mortality rate was 121. Most of the mortality was in the newborn period. One rainy evening, a woman from a village called Khursa suddenly dashed into my house with a very tiny shriveled baby in her arms, emaciated, dehydrated, panting. And before I could do anything, baby died on my bed itself. That was very frustrating. And when I asked the mother, sobbingly she told me whole story. Story was typical: poverty, illiteracy, alcoholic husband, no health care. And finally, when she wanted to bring this very sick baby to our hospital, there was a river full with flood and there was a bridge which was broken. I counted, there were 18 causes of death of this one tiny baby. It was very unequal battle. What could we do? And when we looked at WHO guideline, what could be done for neonates? WHO guideline authoritatively said they must all be sent to hospitals. And hospitals didn't exist. And so desperately then one day I thought, then why not turn it around? If babies cannot go where the healthcare is, then obviously healthcare has to go where the babies are. And that's how home-based newborn care was born. The main causes of why these babies were dying: preterm babies, asphyxia at the time of birth, and infection, which we call neonatal sepsis. So home-based newborn care must address these three major killers of neonate. So community health worker providing a package of care which is scientific, which addresses all main causes of mortality and main morbidity, yet something which is feasible to deliver at home and yet not very costly. All this had to be combined together into home-based newborn care. So I wrote it in the form of a field trial where the concept and this package contents of home-based newborn care will be tested very rigorously. Home-based newborn care had to be introduced in 39 villages so that then we could compare whether did home-based newborn care make any difference. How would we measure the difference? We'll measure if the neonatal mortality rate and infant mortality rate would come down in those 39 intervention areas.
गावामध्ये पोलीस पाटील सरपंच यांच्याकडे आले सर्चमधून आणि ते विचारले का बा एक तर लग्न झालेली असायला पाहिजे, तिला मुलं बाळं असायला पाहिजे आणि लिहिता वाचता येणारी पाहिजे. मग त्याच्यामध्ये माझं नाव दिला.
सिलेक्ट केल्यानंतर आम्हाला 2-2 महिन्यांनी सर्चमध्ये बोलवत होते. पहिले थोडा तापाचा आजार, नंतर मग बाळाला तपासणी कशी करायची, बाळाचा निमोनिया कसा ओळखायचा, हा पण टप्प्याटप्प्याने शिकवल्या गेला.
नंतर आम्ही दर महिन्याला एक शिबिर घ्यायचो. तिच्यावर त्यांचं इव्हॅल्युएशन व्हायचं आणि इव्हॅल्युएशनमध्ये पासिंग आम्ही 90% ठेवलं होतं. तर असं 3 ते 4 दिवसाचं दर महिन्याला ट्रेनिंग करायचं. 1 महिना त्यांनी फील्डमध्ये काम करायचं आणि मग प्रत्यक्ष कामाला सुरुवात करायची. एका दिवशी कमीत कमी किती चिन्ह पाहिजे? 2 किंवा 2पेक्षा जास्त. HBNCमध्ये आरोग्यदूतांचं सुरुवात जे होते ते अपेक्षित जे बाया असतात त्यांची यादी बनवतात त्या आणि 2 महिन्याला ते अपडेट करतात. ती जर गरोदर असेल तर तिचं 4थ्या महिन्यापासून मग ते फॉर्म भरतात आणि गरोदर महिन्यामध्ये 5 व्हिजिट करतात त्या. आणि गरोदरपणात 2 वेळा ते हेल्थ एज्युकेशन करतात आणि आफ्टर डिलिव्हरी 1 वेळा हेल्थ एज्युकेशन करतात. डिलिव्हरीच्या वेळेस ते अटेंड राहतात. तिथे जर बाळ गुदमरलेलं असेल तर बर्थ ॲस्फिक्सिया मॅनेजमेंट करतात. अर्ध्या तासाच्या आतमध्ये त्याला दूध पाजायचं असतं ते ब्रेस्ट फिडिंगचं सुरू करतात आणि मग त्याचं वेईंग करणं, टेम्परेचर घेणं, तापमान मोजणं, श्वास मोजणं हे सगळं करतात.
Newborn infection, sepsis, was the commonest cause of neonatal death. Through analysis, I developed a set of criteria based on clinical signs, symptoms, using which a semi-literate Arogyadut should be able to diagnose neonatal sepsis. Once she diagnoses neonatal sepsis, she should tell family that this is a serious illness, better take to hospital. If families choose not to go, Arogyadut would take the written consent and then she would give antibiotic. 1 oral antibiotic, cotrimoxazole, 1 injectable antibiotic, gentamicin.
आता हा प्रोजेक्ट सक्सेस का झाला तर मी सांगेल की एक तर सिलेक्शन ऑफ द हेल्थ वर्कर तुमचं चांगलं असायला पाहिजे. दुसरं तुमचं ट्रेनिंग चांगलं असायला पाहिजे. आणि तिसरं सुपरविजन जर चांगलं असेल तर कुठलाही प्रोजेक्ट हा सक्सेस होतो.
6 वर्ष मी स्त्री आरोग्यदूत होती. फरवरी 2000मध्ये मी सुपरवायझर झाले. सुपरवायझर म्हणून आम्ही जे काम करतो तर त्याच्यामध्ये आरोग्यदूतांनी केलेलं सगळं काम, जसं बाळंतपणाचा फॉर्म आहे, गरोदरपणाचा फॉर्म आहे, निमोनिया फॉर्म आहे आणि त्यांनी उपचार केलेलं पेशंटची नोंद, वही, स्टॉकबुक सगळं काही चेक करतो सुपरविजनमध्ये. आरोग्यदूतांच्या जसं आमच्यासमोर जेव्हा ती वजन मोजते, तापमान मोजते, श्वास मोजते, हात धुते, हे सगळं करताना तिच्या ज्या काही फॉर्ममध्ये चुका झाल्या असतील त्या चुका तिच्या घरी येऊन तिला समजावून सांगतो.
बरं, नर्स ताईच्या लाल लोहाच्या गोळ्या देते.
In 1995, I decided at the end of the training that we must take really certification, validation and ethical permission from the best pediatricians in the country. So we invited 10 senior pediatricians from all over India, and we showed to them our contents of home-based newborn care, our trained community health worker. They evaluated our community health workers for 2 days, and on the third day, the chairman of the committee, Professor Meherban Singh, who was chairman of pediatrics at All India Institute of Medical Sciences, he said, these semi-literate women of Gadchiroli, Arogya Doots of Search, they know about newborn care more than my medical graduates of All India Institute of Medical Sciences. The neonates are very safe in their hands. Home-based newborn care can be given.
According to data from 2016, over 46,000 women in India die every year due to pregnancy and childbirth-related complications. About 1.2 million children in India die before they are 5 years old, of which nearly 700,000 newborns die in the first month.
गावामध्ये पहिले कसं डिलिव्हरी झाली तर त्याच जशी आता एक खाट टाकली आहे त्याच्या जवळ एक खड्डा खोदत होते. त्या खड्ड्यामध्ये सगळं संडास केलेलं, शी केलेलं सगळे वगैरे कपडे धुत होते. त्याच्यामुळे संडासला बाहेर जावं लागते म्हणून बाईला बरोबर जेवण करत नव्हते पोटभर, आणि तो प्लासेंडा बी आहे ते त्याच गड्ड्यामध्ये खोदून टाकत होते. आता हा गड्डा खोदण्याचा 100% बंद झाला आहे, आणि बाळाला 2-2, 3-3 दिवस दुधाला लावत नव्हते, तर आता लगेच दुधाला लावतात.
The HBNC initiative has been able to establish itself as a scientifically valid and effective approach within the medical community due to the meticulous data it has collected over the years.
आपल्याकडे गाव पातळीवरचे कार्यकर्ते आहेत की ज्याच्यामध्ये स्त्री आरोग्य दूत किंवा पुरुष आरोग्य दूत असं आपण त्यांना संबोधतो, पण ते जसं घरी जाऊन आपण आकडेवारी गोळा करतात त्याच्यामुळे त्याच्यावर आपण विश्वास ठेवू शकतो. दुसरं की आपल्याकडे सगळं पॉप्युलेशन रजिस्टर आहे, गावामध्ये अख्खे इंडिव्हिज्युअल कोण आहेत, किती आहेत, काय आहेत ते सगळं आपल्याला माहिती आहे. त्याच्यामुळे कसं की आपल्या डेटाची ऑथेंटिसिटी, कम्प्लीटनेस फार जास्त आहे.
Neonatal mortality rate to begin with was about 60 in both intervention villages, control villages. The neonatal mortality rate continued around same level with some fluctuation for 10 years in those control area. But in the 39 intervention villages where we introduced HBNC, NMR steeply reduced from 62 and it came down to 26. And then it stabilized at that level. This was unheard of. Newborn mortality, reducing it is a very difficult challenge. And here, these community workers have reduced it by 62 to 70%. And the infant mortality, when we began, it was 121. These villages of Gadchiroli still remain poor, still remain backward. But these women of Gadchiroli, trained community health workers, mothers and grandmothers, and TBAs, they are the 4 pillars of this miracle. What governments could not do, these women in that village could do this miracle of bringing it down to the level of 30. Next year, when Government of India decided its national health policy, it chose the national goal of reducing infant mortality rate to the level of 30, which had already happened in these villages. We published this study in the very well-known medical journal, The Lancet. It created ripples world over about this absolutely new model of newborn care. 5 years later, Lancet brought out a special volume called the Vintage Papers in Lancet. They selected certain milestone papers in the 180 years history of Lancet. And when you come to 1990s, there is this paper from Gadchiroli called Home-Based Newborn Care. To further test whether it could be replicated elsewhere, in a project called Ankur, with the support from Save the Children, by involving 7 NGOs, we repeated this study at 7 different places in Maharashtra. And the neonatal mortality, infant mortality came down by about 50% by the end of third year. On the first day of the year 2003, all those Arogya Doot, 91 Arogya Doot from all over Maharashtra had assembled here in Shodhgram. And with the rising sun, the first sun of Maharashtra, because this is the easternmost district in Maharashtra, Baba Amte gave them oath of saving every child in Maharashtra. With all this scientific evidence, Planning Commission ultimately included home-based newborn care in the 11th and later on in the 12th five-year plan of India, with the recommendation that home-based newborn care Gadchiroli model should become the mainstay of strategy to reduce child mortality in India. Subsequently, National Rural Health Mission incorporated that in the national plan. Ashas, nearly 8 lakh Ashas, the community health worker in the NRHM, it was decided that they will be trained to deliver home-based newborn care. So we prepared the training strategy, we prepared training manuals, health education material, records and monitoring system, and finally it became part of the NRHM. When it was introduced in 2011, we know now the evidence published in the Lancet that from 2011 to 2015 have been the 5 years of fastest reduction in IMR in India, and some of the credit of that goes to home-based newborn care delivered by Ashas all over India. Last year, 11 million rural neonates received home-based newborn care.
When these women started working, we realized that if we want to have a good pregnancy outcome, we should emphasize on mother's health also. Because one cannot separate mother from the child, and child cannot be separated from mother. If child has to be healthy, the mother has to be healthy. There were so many misconceptions about the food, what are good foods for women, especially during pregnancy and childbirth. And the whole emphasis was on child. Like these foods are, the mother should not eat these foods because they are dangerous for the child. Nobody cared about the mother's nutrition, what she requires.
During the home-based newborn care trial and subsequent service delivery also, we were meticulously monitoring the various maternal complaints women had. And the data very clearly pointed that women had several complaints, ill effects, which definitely needed some kind of attention. But because maternal health was mostly equated with maternal mortality, these complaints of the women were not necessarily taken care of. So home-based newborn care anyway had some component of maternal health both during pregnancy and postpartum, but we thought that we must expand it further, especially when we found that 50% of the women had some or the other maternal morbidity. And this essentially was the rationale that we decided to expand the maternal health component and make it home-based mother newborn child care instead of only home-based newborn child care. There was almost 40% reduction in the maternal health complaints. It also led to early identification of any maternal health complaint, immediate starting of treatment, and of course increase the maternal well-being.
The HBNC program of search is pioneering in its focus on the empowerment of the community and the community health workers. While the health worker gets financial incentives for each case she handles, the true reward is in the warmth and respect from the community which cuts across caste and social barriers.
माझ्या कुटुंबामध्ये मुलावर पण त्यांची संस्कृती कशी राहावी, आपण कसं राहावं, आणि माझ्याकडे डॉक्टर लोक येते. मुलांचा पण त्यांना असं वाटलं की हे लोक आमच्याकडे येतात, आमच्या घरी राहतात. माझी आई शिकली नसती तर आमच्या घरी कोणी आले नसते, आणि लोक पण माझ्याकडे चांगल्या याच्यानं पाहतात. त्यांना पण समाधान वाटतं की ही बाई आहे तर बाळं आमचे वाचू शकतात, बाळाला वाचवू शकते.
आणि माझ्या कुटुंबामध्ये सुधारणा, एक तर माझा नवरा खूप पिणारा होता आणि मला माझ्या मुलाला खूप त्रास द्यायचे. मग गावातले लोक चांगले मान द्यायला लागले. त्यांना काय वाटलं का माझ्या बायकोला एवढा मान आणि मी का असं बेवड्यासारखं वागावं म्हणून ते स्वतःहून दारू सोडले आणि माझ्या कुटुंबामध्ये सुधारणा झाली.
And now, last year, home-based newborn care, its principles and methods have been incorporated under various names, but in the national health programs of 80 different countries in the world. WHO, UNICEF, USAID, and Save the Children. In 2009, they made a global resolution that wherever needed, where medical care, hospital care is not available, home visiting and care at home by community health worker is the way to go. Designing logo of home-based newborn care was in a way difficult as well as creative task. And so if you look at that logo, that woman is alone in that hut and baby helpless, and open that window of knowledge, window of opportunity, and that woman becomes empowered and takes care of the baby as well as family. Home-based newborn care is a humanitarian approach, it's a scientific approach, but at the same time, there is also a political philosophy behind it. And the philosophy, we derive it from Mahatma Gandhi, philosophy of Swaraj, where people don't have to become dependent on hospitals, doctors, external sources, but you empower community, empower mothers, and they can take care of their own health, people's health in people's hand, that we call Arogya Swaraj.
हलक्यानी हलवा पाळण्याचा दोर